Summer Laws, representing local public health.
Well, thank you for this opportunity, and thank you to Cerise and Tim, I think, especially for organizing this. As I see many colleagues in the audience from local public health, and I know that sometimes we felt at Boulder County Public Health like we're a little bit out there on our own, looking at how we're going to approach this, so it's great to kind of all get on the same page today. Before I kind of get started into what we're doing in Boulder County, I'm going to talk more about just kind of give some context to where I work. So I know we have a reputation in Boulder County, and part of that is around health and wellness, that I think folks think of us as kind of very health crazed. And then I think the other reputation is that we're seen as being very progressive and liberal. So I think that some folks might be surprised to hear that when you look at substance abuse and mental health in our communities, our rates are actually pretty high. So those are some issues of concern when we look at our population health indicators. And then I think folks would also be very surprised to hear that some of our jurisdictions within our communities chose to implement some of the strictest regulations when it comes to retail marijuana. So I'll tell you a little bit of that story. And before I do that, too, I wanted to talk about how this work in regulation isn't new. So Jana is here. She was one of my mentors in terms of policy and environmental approaches as we look at public health impact and what we can do. But we know that we do this work in alcohol, we do this work in tobacco, we do it in injury prevention, we do it in obesity prevention. So it's really not necessarily new work, it's just a crazy new realm that we're doing it in, because we don't have the information that we usually have. So really, I talked a little bit about how mental health and substance abuse are issues within our county, and I'll kind of explain how we prioritize that. I think many of you in public health are familiar with the 2008 Public Health Act that really asked local public health agencies to conduct a community health assessment every 5 years and then prioritize, according to that assessment, what their agency would do in terms of actions to reduce some of the health issues or the health problems within their community. So through that process, through our strategic planning process, through some of the processes that we're looking at in terms of accreditation, we found that substance abuse rose to the top as one of our key issues, along with mental health, and then we're also kind of looking at healthy eating and active living. And part of that process, we convened a task force, and so the members of the task force are here. There were folks from the medical community, from mental health, from education, and we asked them to look at the data and tell us what should we do then within substance abuse, what are kind of those key issues. And they told us that there were 3 kind of major arenas they wanted to work in, and this was prior to Amendment 64. So those were looking at prescription drug abuse, looking at alcohol abuse, and then looking at marijuana use. So before even retail came to the table, we knew that there was something that we were going to look at. I should also say that within those arenas, we knew that the team wanted to look more specifically at delaying the age of initiation for use of marijuana, and then also overall use substance abuse, because we knew that our kids were using. So the data for our county is that about 25% of high school students report as current users of marijuana. So that's about 4,200 kids in our county, or 84 school buses of kids that currently use, according to our Youth Risk Behavioral Survey. But why did we choose that policy approach, to reducing youth substance abuse? I'll kind of go through each one of these in detail to explain to where we got to. So I'm not going to go more. Oh, that slide didn't work as well. But I'm not going to go really specifically into the evidence, because I don't think that is our role as a local public health agency. I think that was discussed in the morning, and Dr. Thurston and Dr. Riggs probably most specifically kind of talked to the youth harms. But what we really did initially, when we even looked at what was happening after the passage of Amendment 64, we had to decide what were the issues that we were going to address. And so we were digging through the data. We were speaking with experts in the field, And one of the things that we did was something similar to this. So our alcohol diversion coordinator, Katie McGee, who's here in the audience, she was charged with putting together a symposium similar to this one to address the public health impacts of marijuana. So at that symposium, Dr. Riggs and also Dr. Dunmish, who is here today, presented and really spoke to some of those potential harms. So we got to kind of an evidence base, and when we looked at that, it seemed like our community was really ready to take action in terms of youth. We didn't find that there was something definitive in the other areas. There were some special populations that we were looking at in terms of protections, but where we could all come to the table was really to look at youth. So Mary mentioned this, but we also saw that the perception of harm within our communities was decreasing. So this is kind of hard to see, but this is from the 2011 Monitoring the Future survey. That's a national survey that looks at youth. This is 12th graders' perception of harm of marijuana use for occasional use. And so you kind of see that generally we see that they bounce back and forth, that there's that inverse relationship. And what we were seeing in Boulder County since about 2005 was a 20% decrease in the perception of harm among our high school student population. So we knew that from the Youth Risk Behavior Survey. So in the same sense, we were kind of projecting that we might see an uptick of youth use. And this is an area where I'll kind of really explain what that local policy opportunity was that we saw. I think that sometimes that this is kind of unclear within this realm, that folks think that when we talk about regulation that we're talking about legalization. So that's not really what we're talking about here. There was some reference to really what that language was in the ballot measure for Amendment 64, but I kind of break it into two parts to keep it clear in my head. So one part is that it was made basically legal within the state of Colorado, and then the second part is that each jurisdiction within the state of Colorado was able to determine whether or not they would allow the retail sale, production, manufacture of the product in their communities, and to what level they would regulate it. And that's where we saw the opportunity, was within that arena. So again, this isn't new. This is what we do in public health all the time with social host ordinances. We look at density. We look at hours of operation for liquor stores, restaurants, and bars. And tobacco, obviously. We look at taxation. So this wasn't really a new approach. And we knew that 66% of the voters in Boulder County had approved Amendment 64. But when we started to talk about folks, they said, yeah, I approved it for various reasons. But when you were to say something like, well, talking about maybe a retail establishment with a lighted sign next to a children's playground, that wasn't necessarily what they had in mind when they voted yes for Amendment 64. So that's, again, where we started to work. And like I mentioned, there really were a lot of lessons that we could garner from tobacco and alcohol control. So we knew this wasn't going to be brand new work. This was something that we could figure out. And we really had quite a bit of help from our staff that had experience in tobacco control policy, and then our community partners who were willing to look at some of the environmental strategies within alcohol control that we could try to apply to marijuana. So what did we do? I'll try to explain, really try to distill a couple years worth of work into the next 5 or 6 minutes, but I'll start out with just kind of really who we are. So we were kind of an unlikely team. We did create a multidisciplinary team, kind of similar to what Larry, you were talking about. We have folks from environmental health, we have folks from management, from tobacco control, from the alcohol diversion, and we all sit at the same table, along with myself. I'm a health planner, and really had to make that determination of where we're going to approach kind of the public health impacts. And I also mentioned that we have community partners, because some of those folks are in the room, and those partners were able to do some of the work that we weren't able to do. So some could speak really from the personal parent perspective at policy meetings. Some were able to, from the academic world, to really drive in on the data and kind of provide that perspective. And then others were willing to write letters or kind of do more of that community organizing piece of things. So then policy analysis. really what that team had to do was sit down. We created a crosswalk of potential retail regulations that were within each specific jurisdiction that was looking at regulating marijuana. And then we did a crosswalk against what we knew was effective in tobacco control and what we knew was effective in alcohol control, and we looked for gaps. And within those gaps, that's what we took to the policymakers as what they could potentially implement within their communities. But it wasn't really that easy to do. I would say that in the beginning, we just threw tons of data at them. I think as public health geeks, we get really excited about data, and we just put up a bunch of charts, and their eyes glaze over, and they don't listen anymore. So people were getting kind of lost in all that information. But when we brought our communications person to the table is when we got a lot better at this. So we got really succinct. We only talked about a few key data points. And then what we heard over and over again, they wanted to be told what to do. They didn't know what to do in this arena, and they wanted that perspective of what sorts of regulations can we even implement. We're not sure where to start. And what does the public health community think about this? So that's kind of where the relationships are key. And I'll bring it up there because the policymaker relationship was so important in this conversation. The policymakers that were willing to sit down, one specifically, and say, hey, can I tell you what Boulder County Public Health is doing wrong, actually? I mean, you do need to lay it out for us and be very clear, and then bring the language for the regulation to the table, and it will happen. Again, community members, people from the academic community, and then also legal support. So we were able to draw on legal support from within our county government and sit down with some of our proposed regulations, and they could tell us, yes, this is plausible, or this is more of a state level type of regulation, or this could set us up for litigation, et cetera. So it kind of got us prepared for that discussion with our policymakers. And then we did reach out to other jurisdictions. So, we spoke with Mary on the telephone to find out who other contacts. We looked at what other communities were doing to kind of figure out what should our approach be. So I think as public health and scientists, sometimes we really don't have a lot of power and influence within this political arena. But what we do tend to bring to the table is a high level of credibility. And we were able to also bring consistency. So not only were our community partners willing to come speak, that what we heard from one of our policymakers was just a thank you to our Director of Health Programs, Heath Harmon, who was there every night with his team, willing to stay till 2 a.m. and talk about these regulations, which is not what we normally do in public health to that level. And so that consistency and being really data-driven and professional, we were able to bring that voice to the decision makers. So I make this sound like it was so easy, but it was pretty fast-paced and pretty intense for a long time, and it still is. We didn't realize how labor-intensive this was. So we have a team that meets weekly and is looking at kind of what's coming up in terms of our docket with other policymakers or other jurisdictions within the county. We had to do an immense amount of research even to get us down to looking at youth harms, because there was so much disagreement even within the public health community about what sort of harms should we be looking at. It's very fast-paced, as you all know. Any of you that do policy work, it changes. We don't know when the council meetings are going to be. And there are limited partners who are willing to come to the table on this, that this is something that people don't want to stick their neck out on. They're afraid that regulation or proposing regulations is the same thing as being against legalization. And there's not that clarification oftentimes. And so when you ask someone to speak about this in terms of protecting youth, they get nervous. So people aren't ready to go there sometimes. And then just really those diverse viewpoints, like I said, that public health wasn't sure what we should do within this arena, so that was a challenge. But we have had some successes in this work. So one thing that we consider success is that we saw some consistency in terms of the regulations across the different jurisdictions within the county for those public health protections. So I mentioned special populations, but we did not only just look at youth protections, we were thinking of pregnant and nursing mothers, we were looking at drug driving, some other issues too within communities. We also were able to put sometimes some stricter regulation around density and setbacks at the local level. So those setbacks are just how close the retail market can be to child care centers, to schools, to substance abuse treatment centers, et cetera. So we kind of added to that list sometimes. Another thing that we could do as regulators was, or suggest as to the regulating community, was that they require ID scanners, which is something that we know, for those of you that work in alcohol control, know that is considered a best practice. We looked at hours of operation. That's something we also learned from alcohol. And something new that we kind of looked at was sustainability. So being Boulder County, we couldn't leave that off the table. But we knew that there was a lot of energy that's used in grows, especially in Colorado, for lights and ventilation. And so one of the things is that we require that in some jurisdictions that those companies purchase their energy from sustainable resources or sustainable sources. We put some stricter regulations in some communities around marketing, some things that we knew from tobacco control about couponing and giveaway of promotional products and how that affects youth. But probably the biggest success were the relationships that we made with policymakers. So when we bring another public health issue to the table, they want to have that conversation. And so my speech today really was to just say that this is something that other agencies can do, and that it wasn't as difficult as sometimes it sounds, and that there are a lot of resources out there, as you heard today. It's very interesting work, as anybody who's now working in this knows. It's that we have reports and research that come out weekly, sometimes it seems. But most importantly, that there's this potential for broad population-level health impact. And that's what we're charged with in public health. So if you have any questions or looking for resources, feel free to contact any of us on that team, and thank you.
Thank you, Summer. So Dr. Wolk or Mary, do you have questions for Summer?
Yeah, not so fast. I was just going to turn your question to me kind of around back to you, and to put the pressure of all the local public health agency folks that are here today and say, if you had one thing that you could recommend to the state, so not just CDPHE, but how the state can actually help your efforts, what would that be?
Well, one of them you're already doing. I think that's around messaging. So one of the priorities for that task force that's now turned into an implementation team for our public health improvement process, one of their priorities is integrated messaging around this, that we don't have that in marijuana. And so it sounds like that's what you're in the governor's office are charged with. So we're waiting. We're not going to create something new. We're hoping to build upon what you create. Yeah.
Thanks.
Mary?
So you talked about all the different partners that came around the table and how some people wanted to stay away and some didn't. One of the things I've seen is that we've had people around our table in terms of developing rules that we've never worked with before, and it's really kind of exciting to see that kind of collaboration. So as you look at the partnerships of the local communities, who surprised you the most, or what sector by kind of being reluctant to participate, and who surprised you by being willing to participate? And then who do you think would be, if you had your choice, who has to be at the table?
That's a big question. Let's see. Maybe first I would talk about, we were kind of surprised at how we weren't as used to working even across divisions within our agency as well. So when we didn't know about a lot of the work that environmental health had already been doing, and at the state level, we weren't connected to all that at that team level until we brought folks to the table. So we didn't have as much experience working with the other divisions and cross-divisionally with environmental health. Let's see. At the community level, we have folks from the university, from city governments, from kind of and community organizations, parents. I'd say we have the usual folks there, but it's really the clinicians who aren't ready to talk about this. Medical providers did not want to speak about this versus academics. Because that group was looking at reducing substance abuse, the medical providers are saying, well, really, when you look at opioids and what's happening with prescription drug, that's what we need to be focusing on more, and I'm not as concerned about marijuana right now. So that was surprising. Yeah.
Summers, I have a question for you. How did you involve Latinos or African American, particularly the community organizations, nonprofits, or just community members? Or are you going to?
Well, I think we're just starting to do that. For our public health improvement process, we've been looking at health equity, basically working with the Colorado Trust on a process, and I think some of you might be familiar with the health equity learning series that they do as kind of this ground base of what we look at. And then within substance abuse, I guess the biggest disparity that we saw was the disparity affecting the gay, lesbian, transgender, and queer questioning community. And so that's one of the areas I think that we're looking at expanding on. We have some folks at the table, but we're looking at building that, I think, out even larger.
That's great. Thank you very much to all the speakers.